My name is Stuart Campbell. I'm one of the thoracic surgeons with Hackensack Meridian Health in the southern region. Some of the questions that I will try to answer today are, what are the most common types of lung cancer? I've been diagnosed with lung cancer. Now what? What are my treatment options and who do I need to see? And after treatment, what does my follow-up look like? So lung cancer, it's the leading cause of cancer-related death in the United States, with an estimated 226,000 new lung cancer cases in the U.S. in 2025. So really huge numbers when it comes to lung cancer. And one of the things we learned from Dr. Jeffrey Peltz's talk in the first episode is early diagnosis is really important and critical for improved survival. And lung cancer screening, we can't emphasize enough on how important that is and how important it is in early detection of lung cancer. The diagnosis can be made through multiple ways. So radiology, needle biopsy, endobronchial needle biopsies, surgical excisional biopsies, and like I said, Dr. Jeffrey Peltz did a great job in his first talk in this episode series, talking about lung cancer screening and diagnosis. So I won't dive into detail on the diagnosis part of things, but this talk is going to focus a lot on, after I've been diagnosed with lung cancer, now what do I do? So first things first is don't panic and breathe, and that's my lung cancer pun. So lung cancer is not one disease. The type of lung cancer and the stage of lung cancer are very important. And the treatment algorithm, the prognosis can range significantly based on the type and the stage of lung cancer. Usually when we talk about lung cancer, we break it down into two main categories, one being small cell lung cancer and the other being non-small cell lung cancer. Within that, there are subcategories as well, which I will talk about. Staging and multidisciplinary treatment approach are the next important step. So you've been diagnosed with lung cancer. We need to know what stage it is, what type it is, and get the appropriate treatment team involved to get you where you need to go. This treatment team consists of a wide variety of both physician specialists and nursing specialists. So primary care providers, pulmonologists, medical oncologists, radiation oncologists, thoracic surgeons, our nurse navigators. All of these individuals play an extremely important role in navigating your treatment algorithm and your continued care. And we have multidisciplinary meetings and multidisciplinary approach treatment to all of our lung cancer patients. And I put up a figure here on the right-hand side, and this can just show you sort of the extreme differences in lung cancer and the 5-year survivals. And so you can see with the non-small cell lung cancer on the left-hand side, early diagnosis and early stage can have a very good 5-year survival versus when we find things late and things have already metastasized and spread. It's a much more challenging disease to treat. Small cell lung cancer, again, the 5-year survival is much more challenging because this is a much more aggressive form of lung cancer. And when we find it, it's very frequently already spread throughout the lymph nodes and throughout the body. So small cell is a much more challenging disease. So staging is very important after your diagnosis. We need to know, is this localized disease to one spot, or has this spread to lymph nodes? Has this spread to other organs in your body, like your adrenal glands or your brain? So CT scan is sort of the first part of the staging, and frequently that's where we make the diagnosis or the initial concerning lung lesion that's found or target. And so CAT scans involve CAT scans of the chest, but also of the abdomen and pelvis to look for disease elsewhere. A PET-CT scan is in the staging algorithm for lung cancer. And what this uses is a radio-labeled sugar molecule that's injected into your bloodstream. And areas that are active in your body light up bright with a PET scan. So things like infection, inflammation, and cancer can all light up bright with a PET scan. So you can see here in the middle image on the PET scan, you have your brain, right, at the top is very active because we're always thinking the brain uses a lot of sugar. But also there's the one spot in the lung here that is a bright lesion. And again, that goes to show the concerning spots within your body that are active and taking up a lot of sugar. That can help show us if disease has spread, if disease might be in your lymph nodes, and gives us additional information on what your stage might be. And then imaging of the brain is also important. Lung cancer will frequently metastasize to the brain, especially something like small cells. So making sure that we're looking at the brain, that there aren't any lesions that are hiding there is also very important. So this is a very complex slide looking at staging, and I put this up mainly to show you that for lung cancer, the staging algorithm is complex, and the treatment algorithm depends a lot on your stage. However, if we focus just on the left-hand side, I tried to break it down into a little bit simpler. So whenever we look at lung cancer, or most cancers really, we use a staging algorithm that looks at the size of the tumor, looks at the lymph nodes and whether or not lymph nodes are involved. And then we look at metastasis to see, has this lung cancer spread outside of the lung, spread outside of the lymph nodes and gone somewhere else. And that helps us to determine the staging when we use these three things. And stage 1 is an early stage, and this is usually something that is localized and small. So a smaller cancer that has not spread yet. Okay. As we move on in staging, so stage 2, again, this is either a small cancer that maybe has gone to some very nearby regional lymph nodes, or a larger cancer to begin with. And then stage 3, now we're spreading to more lymph nodes, or we're a really large cancer. And then stage 4, now this has spread beyond the lung and the lymph nodes to other regions in the body. So why is all of this important for the staging? Well, we need to know if we are treating one single site or have things already started to move, and we need to target not only the one cancer itself in the lung, but also the lymph nodes, also other organs. And so it changes whether or not we're talking about a localized therapy with something like surgery or radiation, or we're looking at treating the cancer systemically. We need to treat as if the cancer has gone multiple places in the body and treat you with something like chemotherapy or immunotherapy. So staging is incredibly important. How do we stage? So we have our imaging algorithm, so the CT scans, the PET-CT scans, and the MRI, so that can help tell us areas that are suspicious. But then we need to do things to confirm that there is cancer that has moved elsewhere. So some of these staging procedures are things like our interventional radiology biopsy. So our radiologists are fantastic at putting needles into very tight spaces and sampling tissue. This can be done in the lung, it can be done in lymph nodes, it can be done in other organs like the adrenal gland. And they're able to put a needle in very small places and sample to help tell us yes or no, cancer has moved to one of these spots. In the middle there, EBUS, so that stands for endobronchial ultrasound. What this lets us do is we go down your airway, okay, with a specialized camera, And we're able to identify lymph nodes within your mediastinum or within the lung region. And we can pass a small little needle through the airway into these lymph nodes to help tell us that cancer, yes or no, has moved to some of these lymph nodes. This is a procedure that can be done the same day. You come in, you get your endobronchial ultrasound, and you go home the same day. So it's a pretty minimally invasive way to sample the lymph nodes and gives us a ton of information on your particular cancer and whether or not you have any cancer that has moved to lymph nodes. Another way to sample some of the lymph nodes is called a mediastinoscopy. Again, this is through a small little incision in the neck, and we pass a specialized camera down in front of your airway into the mediastinum again to sample these lymph nodes. It gives us nice tissue, nice good sample. Again, a same day procedure. You come in, you go to the operating room, you can have your mediastinoscopy and go home the same day. But it really helps narrow down where your cancer is and changes the treatment algorithm a lot if you do have lymph nodes that are positive. So staging is very important for helping to determine our treatment algorithm. Again, why does stage matter? Well, this is a nice graph that really shows the stages and the 5-year survival rates. And you can see from stage 1 to stage 2 to stage 3 to stage 4, you get a decrease in survival along each way. Now, again, this just really highlights the importance of proper staging and early diagnosis of lung cancer, because those numbers in the stage 1 and stage 2 are getting better, and we continue to get better with new treatments and new technologies. But the further the cancer has spread and the later that we diagnose it, the more challenging it becomes to treat. And when things have moved and they're in the later stage, our treatment algorithm switches from a localized treatment to systemic. So now we're looking at things like chemotherapy, immunotherapy, radiation therapy. Versus we catch things early, we can do surgery and sort of go for a curative intent or radiation on spots to treat small early stage disease. So the other important thing that I had mentioned was the type of cancer. So stage, incredibly important. Lung cancer subtype, equally as important. And we break down, I've broken down lung cancer here into there's 2 main groups, and then I threw metastasis in. But the 2 main groups are small cell lung cancer. Again, this is about 15% of lung cancer diagnosis. It is almost always associated with a history of smoking. Okay? It's a more aggressive cancer. Frequently has already spread or metastasized at the time of diagnosis. And because of its aggressiveness and the later stage of diagnosis, treatment almost always involves chemotherapy and radiation therapy, and very rarely is surgery involved in the small cell treatment algorithm. There are some instances where we do find a very early small cell cancer that has spread nowhere, but it's much less common. Non-small cell lung cancer is the majority of lung cancer. So 80% of lung cancers are non-small cell. The 2 most common within that category are adenocarcinoma and squamous cell carcinoma. They comprise the most of non-small cell lung cancer. You can find non-small cell in both smokers and non-smokers. Again, there's an increased association with smoking. However, you can get lung cancer if you've never smoked in your life. Treatment algorithm for non-small cell includes surgery very commonly, especially if we find it early, chemotherapy, radiation therapy, and immunotherapy. These are all in the treatment algorithm. And then metastasis. So this is not actually a primary lung cancer. This is another cancer that has moved to the lung. Okay. And we do see this if you have a nodule that's detected on a CT scan, for 5% of the time, it can be a metastasis and a cancer from somewhere else. So frequently, these patients will have a history of cancer elsewhere in their body. Okay? And again, surgery is certainly can be in the algorithm for metastasis if it's isolated disease. But more commonly, chemotherapy, radiation therapy, and immunotherapy as well. Focus on whatever the initial cancer of origin is. So, diving down a little deeper into small cell lung cancer. So, like I said, 10 to 15% of lung cancer. The more aggressive form of lung cancer, frequently found at a later stage. The staging algorithm still includes a CT scan, a PET-CT scan, MRI of the brain, and oftentimes bone imaging if there's suspicion on either the PET-CT or a CT scan. We sort of break small cell down into staging as well. So limited stage surgery can be in the algorithm, like I said, if the mediastinal node assessment is negative and there's no signs of disease outside of that initial primary cancer. Not very common that we make the diagnosis early enough to offer surgery with small cell. Sometimes we actually go in to operate on lung cancer thinking that it is a non-small cell, and it turns out to be a small cell after resection. So, but again, it's more of a rarity. Then we move to limited stage with positive nodes. Okay, so the treatment in this instance usually involves chemotherapy and radiation therapy at the same time. So small cell, because of its very aggressive nature, actually typically responds incredibly well to initial treatment. So you can have profound shrinking of tumors in the beginning. The challenge is the recurrence with tumors coming back. Extensive stage, so now we're talking about small cell cancer that has moved outside of the lung, outside of the lymph nodes to areas like the brain, to the liver, to the adrenal. These patients typically get started with systemic therapy. And then a lot of our treatments are focused on supportive care and palliative care. So with metastasis to the bone, we can offer radiation to help with pain. Metastasis to the brain, we can offer things like radiation to the brain as well to help with neurological symptoms. So, as with every cancer, there's an individualized treatment, which depends on symptoms, location of disease, and performance status of the patient. Moving on to non-small cell lung cancer. So like we said, this is the majority of lung cancer, comprising of 80% of lung cancer. And you can see a breakdown in the pie chart there of lung cancer types. So blue being the non-small cell lung cancer is taking up most of the pie. Within that, we have adenocarcinoma and squamous cell carcinoma taking up, again, the vast majority of the pie. And then the rest of the pie can be other variations of cancer, such as large cell neuroendocrine tumors. We have carcinoid tumors. There's sarcomatoid carcinoma and things like mesothelioma. Again, much rarer, but we do certainly see these things. So treatment options for non-small cell lung cancer, again, whether the disease is localized to a single spot or has spread to distant disease, greatly changes the treatment algorithm. So, but the three main things that we use with non-small cell is surgery, radiation therapy, and chemo and immunotherapy. So surgery. So I'm going to spend a little time diving into surgery, mainly because I'm a thoracic surgeon and this is what I do. But so surgery, early on, all surgery was done through a thoracotomy. So it's a little bit historical here, but the first cases of thoracotomies were sort of in the late 1800s, early 1900s. In the beginning stages, certainly there was higher morbidity and mortality. However, as we've improved anesthesia, as we've improved improved antiseptic techniques, have greatly improved our surgical outcomes when it comes to lung cancer surgery. Thoracotomy is still something that we do perform for certain large tumors or certain reasons why we can't do minimally invasive surgery. However, certainly I would say the standard of care is moving to much smaller incisions and what we call minimally invasive surgery. So one of those things is called a VAT, so a video assisted thoracoscopic surgery. And this was starting to be performed more in the early 1990s and the 2000s, and much smaller incisions, great visualization with the camera, allow for really a much quicker recovery and a less morbid procedure. And so it allows us to perform very complex surgery through 1-2 centimeter incisions, and patients can leave the hospital the following day. So as technology has improved, now I would say almost 90+% of lung surgery at Jersey Shore is performed what we call robotically. So robotic minimally invasive surgery. Again, small, 1-2 centimeter incisions, a very powerful camera that allows us to see incredible resolution within the chest. You can see here, this is actually the surgeon sitting down at a console controlling 4 arms at the same time. So really improved control for the surgeons, and allows for very complicated thoracic surgery to be performed through really small incisions. And this really has improved surgery and outcomes. So patients have much less pain, much less morbidity. They can come in, get their surgery, and 90% of the time leave the hospital the following day. So the advancements in surgery have been incredible over the past several years, and continue to improve. So in addition to improving our surgical technologies, surgical research has also allowed us to focus on lung sparing surgeries as well, and saying, do we have to remove a whole lobe of the lung, or can we preserve and save more lungless surgeries? And so what we've shifted now a lot to is something called a sublobar resection, and actually preserving more and more of the lung while not compromising our oncologic outcomes. And you can see some of the technology here that we utilize with the robot, and this is actually a special dye that's injected into the vein, and it can help light up the blood supply of certain parts of the lung, and really allow us to do lung preserving surgery with really complex, we call segmentectomy. So again, really great advancements in our surgical procedures. In addition to lung preservation, we have great advancements in lesion identification. And so when you have your hand in and you're feeling the lung, it's really easy, or typically easy to feel a small lesion. Now when you're using a robot and trying to preserve as much lung as possible, sometimes identifying small lesions, or we call them ground glass lesions that are semi-solid, that can be challenging. And with our improvements in lung cancer screening and identifying lesions early and earlier, what allows us to then provide early treatment for smaller and smaller lesions. But we need to be able to find these lesions in order to surgically remove them. And so one of the improved technologies is this machine called the ion robotic bronchoscopy, and it allows us to navigate out in the lung to really challenging areas, to really small lesions, and we can label these small lesions in a way that we can then identify them in the operating room, again making sure that we remove the lesion and preserve as much lung as we can. So you can see here on these images, all these green spots are again these coils that are labeled with this special dye that we can see in the operating room. and allows us to resect really early lesions with really great surgical precision. So some really amazing surgical advances that we can utilize nowadays. And here's another surgical advancement or another tool in our arsenal, something called cytolux dye, and this is again another lesion or another marker connected to actually folic acid receptor that you can inject preoperatively. And cancer cells that are very active take up a lot of this folic acid, and so you can see here, this is a lung cancer that is essentially glowing in the operating room, and um, again allows us to perform really nice lung preserving surgery and be sure that we're adequately getting margins and resecting the lesion. So when it comes to sort of our surgical advances, I think it's been fantastic, and our ability to now target really early lesions with surgical precision, and go for curative intent with early lung cancer. So just a recap on surgery as a treatment option. So the goal really of surgery is for a curative intent. So the goal is to remove all of the disease. At Jersey Shore, 90+% of lung cancer surgery is performed minimally invasively, and I would say most centers around the world are certainly moving towards trying to do things minimally invasively, just because the patient outcomes are great. The morbidity is decreased a lot. Most patients spend one night in the hospital and leave the next day. So surgery within the treatment algorithm for early localized disease, upfront surgery is frequently offered, especially if patients have appropriate cardiopulmonary reserve. So your heart can tolerate the surgery, and your lungs have enough function to tolerate the surgery and tolerate the resection. So preoperative planning is obviously really important for these patients to make sure that surgery is going to make you better. Surgery can also be offered as an adjunct after chemotherapy, radiation therapy, and immunotherapy. So, like I mentioned, surgery, the goal is to remove all of the disease. So, if the lung lesion is really large, or it looks like the lung cancer has spread to some of the lymph nodes, we will oftentimes treat with upfront chemo or upfront chemoradiation or immunotherapy to try and either shrink the disease or treat the lymph node aspect of the disease or keep things contained, and then go in and do surgery and try to remove all of the cancer that is present. So surgery can also be used in that instance. And surgery can also be used in a setting where if in the initial process it doesn't seem like surgery is going to get rid of all the disease. Sometimes we treat with chemotherapy and radiation therapy, and we have really an amazing response. And the disease seems to now be localized or not spreading. Surgery can be offered in what we call a salvage setting, where we go in then after the fact and go in and remove as much of the cancer, trying to achieve a curative state at that point. So surgery can sometimes come in after the fact in a salvage setting as well. And you can see here there's different types of lung cancer surgery. Like I said, we have our wedge resections trying to preserve lung, and our segments again trying to remove parts of a lobe. But very frequently we still do lobectomy, and we can even perform things like pneumonectomy, where we remove an entire lung for a big lung cancer. The good thing is that we have two lungs, and frequently individuals can tolerate removing a lobe or even removing a whole lung and live essentially a normal lifestyle. All right, so moving on to another treatment algorithm or another treatment modality, radiation therapy. So radiation therapy has improved a lot, where we can, the radiation oncologist can focally target very, very small lesions with minimum side effects. So radiation therapy can be used for very small early lung cancers that are localized to a single site and called it SCRT. So this is very localized radiation to a single site. And this is great for individuals who don't have either the heart, the cardio function to tolerate a surgery, or they have bad COPD and don't have the lung function to tolerate surgery, or individuals who simply don't want surgery. The radiation can be really effective in treating some of these small early lesions. Radiation can also be used concurrently with chemotherapy, and so chemotherapy is oftentimes great at sensitizing cells to radiation therapy. So it helps prime the tumor cells to be sensitive and makes the radiation more effective. And this can be done on lesions in the lung or lymph nodes that have disease in the mediastinal wall. And radiation is great as well for treating palliative symptoms. So bony lesions causing pain, or brain lesions, or if you have tumors that are causing a cough and obstructing airways. And so it can frequently be used to help treat some of the symptoms in a palliative fashion as well. And you can just see here some of the mapping that goes into radiation and how well they can really target a lesion with minimal sort of radiation side effects to surrounding tissue. Chemotherapy and immunotherapy. So again, these are medications that are given systemically, so given through an IV or something called a port. And this goes, chemo and immunotherapy spread throughout the body, so they target cancer cells essentially everywhere in the body. So with advanced disease or disease that has spread, this is really the most important part of the treatment because it targets everywhere. It can be used, like I said, before surgery to help either shrink things down or treat distant disease that then you're surgically trying to resect. It can be used with radiation therapy to help sensitize the radiation. Or it can be used as its own standalone therapy to try and treat metastatic disease or more advanced disease. And as we continue with our research and looking at genomic profiles and identifying new targets, there's huge advances in chemotherapy and immunotherapy, really almost on a daily basis, coming out with new drugs that have decreased side effect profiles that are more specific at targeting cancers. And it's really it's amazing advances in the field of chemo and immunotherapy. So one of the additional treatment options that I just wanted to mention is something called ablative techniques. And so this can be done with either a interventional radiologist or with one of your thoracic surgeons. And it's one of the new devices that we have here at Jersey Shore, but it's a pulsed electric field ablation called the ELIA technology. And the goal of ablation, it can be either thermal ablation. This particular technology is not thermal. It is a electric field that actually breaks the tumor membrane, causing cell death of the tumor. But in addition to that, it breaks the membrane and releases proteins from within the cell that then the immune system can identify and target and increases your immune response to those cancer cells. So this is something you can do via navigational bronchoscopy, target peripheral lesions, sometimes that more advanced disease. You can ablate some of these lesions and hopefully increase the response of your immune system, or increase your response to immunotherapy or systemic chemotherapy. So again, another technology that we have in our arsenal to help treat lung cancer. So many options. What is right for me? Well, it really is personalized medicine. So it depends, like we talked about, on the type of cancer, the stage of cancer, and your performance status and what your goals are for your care. Um, Multidisciplinary treatment team is incredibly important in determining what the best treatment algorithm is for you. So, we are certainly going to treat some, patients who have the ability to tolerate surgery differently than patients who can't tolerate surgery. Um, and so we really try to individualize everyone's cancer treatment to align with what disease they have, what the status of the disease, and really what their goals of care are and what's important to them. So, follow up for lung cancer. So again, depends on what your initial disease was, but generally, if you have an early stage disease and it's all been resected or treated, we usually do a CAT scan every 6 months for the first couple of years, followed by yearly CT scans for up to 5 years at least. So at least follow up for 5 years. Now, if you have more advanced disease and you're on chemotherapy or maintenance immunotherapy, it's going to be more frequent office visits, usually every 3 or so months, with more frequent CAT scans and PET-CT scans. And then within your follow-up, it's also important to manage the side effects, either from treatment or emotional and psychological challenges. And so, again, that's where our multidisciplinary team approach with our nurse navigators and so forth become incredibly important to make sure that we're not just treating you and then sending you off. We're treating you and managing your side effects and the emotional and psychological challenges that come from having cancer. So what's the future? Well, future of lung cancer, there's a ton of clinical trials for lung cancer looking at radiation and surgery, and different chemotherapies, immunotherapies, and so a lot of clinical trials ongoing. Things like breath tests for early cancer diagnosis, trying to breathe into a machine and having the ability to pick up a lung cancer just by breathing into a machine. Things like that are under investigation. Improved technologies in the OR, and of course, improved screening protocols for early detection. So, I know it's a huge topic, but I wanted to leave a couple minutes for questions. Thank you so much for allowing me to participate in this talk, and I'm happy to field any questions. Thank you very much.
Thank you so much. So before we get into the questions, I see there are a couple of questions in the Q&A. There were some folks that emailed before, so I just want to start with those, if that's okay.
Sure.
Somebody said, I have COPD. Does that require surgery?
So COPD, again, is another disease entity that comes in a lot of shapes and forms. And so most of the time, COPD is managed by our pulmonology colleagues, and it's typically managed with smoking cessation and with medications, including inhalers and so forth. So typically, we do not operate on COPD. There are some forms of COPD where you have really severe emphysematous disease in certain area of your lung, and something like a lung volume reduction surgery is available, but that is a very end stage COPD and a very specific type of COPD. But no, COPD itself is not typically a surgical entity.
Okay. I'm trying to quit smoking. Does vaping cause lung cancer? Is it safer than smoking?
Mm. Um, that's um, that's a tough one. Vaping is still very new. I think there's a lot of data out there that we haven't quite narrowed down on when it comes to vaping. Now, um, we know that smoking is bad for your, can increase your risk of cancer and is not good for your lungs. Um, Vaping involves taking chemicals and turning them into steam and inhaling them into your lungs. Again, um, I it's something that certainly I think causes damage to your lungs, and I think as time goes on here, we will narrow down more and more the type of damage and the type of associations that go into vaping. And so I think there are a lot of different tools for quitting smoking, nicotine replacement, medication, therapies, breaking habits. And I think those are likely better ways to quit smoking than to trade inhaling one agent for another agent.
Great point. I saw something about breathing in different toxins like asbestos, fire, smoke, and other particles. How do these breathable toxins cause cancer, and do they cause cancer?
Yeah, so certainly there are environmental exposures and environmental toxins that can contribute and be associated with cancer. And asbestos is one of those things that we know is associated with a cancer called mesothelioma. And so there's no question that environmental exposures can predispose and be associated with lung cancer as well. So it's not just smoking, but yeah, chemical inhalation in other forms absolutely can contribute to lung disease and lung cancer.
The next question, let me see. How common are lung transplants for patients with cancer?
So the short answer is, and typically to be a candidate for a lung transplant, you have to be cancer free for a period of time. And so, unfortunately, if you have cancer within your lungs, we can't just remove all of your lungs and put new ones in there because with a lung transplant, you have to be on immunosuppressant medication, and those sort of provide an environment for things like a cancer to go unchecked because your immune system is dampened. So, um, lung transplant, unfortunately, is not in the treatment algorithm for lung cancer because of that.
Okay, and then this is the last one that I got via email, and then I saw a couple in the Q&A. So if I get genetic testing and there are no indicators that I have a gene mutation or that I'm predisposed for lung cancer, should I still get screened?
So, when it comes to lung cancer screening, there's or cancer in general, there are ones that you can be predisposed to because of your genetic profile, and then there's ones that happen sporadically and out of nowhere. And so, certainly, if you are a smoker, current smoker, or former smoker, and haven't quit within the last 10, 15 years, and you meet criteria for lung cancer screening, then absolutely, I would advocate, no matter what your genetic profile is, that if you meet criteria for lung cancer screening, that you should get your low dose CT scans and lung cancer screening. The one thing we can't harp on enough is the early detection and early diagnosis, and how important that is.
Have there been any indications about a connection between COVID and lung cancer?
No, I don't have great evidence that I know of linking COVID to lung cancer. Certainly, getting something like COVID increases your chances of getting a CAT scan and increases your chances of identifying a lesion. But when things have only been around for a couple of years, a lot of times we don't make any connections until later on. So, yeah, like I said, no, not that I know of having a link between COVID and lung cancer.
Thank you so much, Dr. Campbell. I really appreciate you taking the time. This was very informative. I'm going to send, like I said, these questions. Some of them are a little too clinical, but I want to make sure that this person gets the answers that they need. And so I thank you very much for your time and you educating us on a lot of this. And I hope you have a good afternoon. And thank you to those who attended.
Yeah, thank you very much for the chance to talk about lung cancer, and I apologize for the technical difficulties at the end here, but
Oh, no.
It's a very big topic with a lot of individualization when it comes to lung cancer. So certainly, if anyone has any questions or wants to reach out, I'm happy to help answer any questions in any way that I can.